Hello, my name is Erica Christensen, and I'm a forensic scientist with the Center for Forensic Science Advancement and Application at RTI International. Thank you, everyone, for joining us today for the Molecular Autopsy Implementation Expert Panel. Part one of this event included 5 pre-recorded presentations from many of the experts you'll be hearing from today. And if you'd like to learn more about the work being conducted through the New York City Office of the Chief Medical Examiner, all of those presentations are archived and available for viewing at any time. Today's event will be featuring a multidisciplinary panel of experts. We will be discussing the current state of molecular testing within the medical legal field, how medical examiner and coroner offices can implement genetic testing, considerations for reporting genetic results, how genetic testing can impact the lives of the living, and how genetic counselors can help convey results and provide guidance to family members. And so with that, I'd love to welcome all of our panelists to join us today. Excellent. As you can see, we have a very full room full of expertise, so we look forward to this discussion. Starting off, we have Dr. James Gill. He is a forensic pathologist currently serving as the Chief Medical Examiner for the state of Connecticut, and was formerly a Deputy Chief Medical Examiner for Bronx County in New York. Dr. Jason Graham is also a forensic pathologist currently serving as the Chief Medical Examiner at the New York City Office of the Chief Medical Examiner and is a clinical professor and chair of the Department of Forensic Medicine at NYU Grossman School of Medicine. Dr. Celine Gounder is an epidemiologist currently serving as a CBS News medical contributor, is a senior fellow and the editor-at-large for public health at KFF and KFF Health News, and is a clinical associate professor of medicine and infectious diseases at NYU Grossman School of Medicine. Dr. Susan Liebman is a geneticist, distinguished professor emerita at the University of Illinois at Chicago, research professor at the University of Nevada, Reno, and author of The Dressmaker's Mirror, a story of an Ashkenazi Jewish family, genetic risk, and research. Dr. Robert Marion is a medical geneticist at Montefiore Medical Center and the Albert Einstein College of Medicine, and is the founder and co-director of the Montefiore Einstein Cardiogenetics Clinic. Dr. Catherine Pineri is also a forensic pathologist currently serving as the director of Montgomery County Forensic Services in Texas, and is also a past president of the National Association of Medical Examiners, or NAME. Dr. Barbara Sampson is a cardiac pathologist currently serving the Mount Sinai Department of Pathology as the vice chair for strategic laboratory initiatives and academic affairs, and is a former chief medical examiner for the NYC OCME. Sarah Saxton is the genetic counselor of the Molecular Genetics Laboratory at the NYC OCME and is also a clinical assistant professor at NYU Grossman School of Medicine. Monisha Sebastian is the senior genetic counselor at the Children's Hospital at Montefiore Medical Center and specializes in rare diseases, cardiovascular genetics, and immunogenetics. Dr. Michelle Stram is a forensic pathologist currently serving as a senior medical examiner at the NYC OCME and is also a clinical assistant professor at NYU Grossman School of Medicine. And finally, Dr. Yingying Tang. She is a medical geneticist and the director of the Molecular Genetic Laboratory at the New York City Office of the Chief Medical Examiner. And Dr. Tang is going to kind of lead us off with telling us a little bit more about her NIJ-funded projects and a little bit more about how we assembled our panel of experts. So with that, I'll take it to Dr. Tang.
Hello, everyone. Can you hear me well? Okay. Our moderator, distinguished panelists, and virtual participants. It is a great honor for me to speak to you today. I'm Yingying Tan. For the past 20 years, I had the privilege of building and leading the Molecular Genetic Laboratory in New York City Office of Chief Medical Examiner. Our office is affiliated with the New York City Department of Health and mental health hygiene. We serve families, communities, and the criminal justice system. We provide answer for those affected by sudden tragic loss and help protect public health. Our molecular genetic laboratory is College of American Pathologists accredited and is the first and only such laboratory based in medical examiner's office in the United States. Our laboratory provides post-mortem molecular diagnostic testing, also known as molecular autopsy, to identify and interpret gene changes that may explain sudden death. Our laboratory also provides genetic counseling service with an in-house certified genetic counselor who interpret testing results family and when needed, refers surviving loved ones to clinical care partners in the New York City. Before we dive into our discussion today, I would like to take a moment to express our deep appreciation to the National Institute of Justice for their invaluable support in making today's event possible. This gathering is generally hosted by Forensic Technology Center of Excellence and RTI International, with Erica serving as our project manager and a moderator. I would also like to extend our gratitude to NIJ uh, for their unwavering support in the successful implementation of post-mortem molecular genetic testing in our office over the past decade. Through 4 research development grants, NIJ has not only funded dedicated scientists, genetic counselor, but also provide necessary reagents and instrument required for testing panel validation, variant characterization, and testing old unresolved cases within our office. So I think today when we get together, not only to discuss our topic at hand, but also is a way to celebrate achievement of NIJ. Their vision and trust in the capacity of our office has been instrumental in our success. Next, I would like to extend my heartfelt appreciation to our distinguished panelists. Some of the panelists I have known and worked with me for years. Dr. Sampson hired me 2 decades ago to build a molecular genetic laboratory in our office, and we have been working closely ever since on cases require our laboratory expertise. Dr. James Gill, our former Bronx Borough deputy chief during my early years at OCME, we have collaborated on various writing projects, and his dedication to public health and advocacy for high forensic practice standards has always been inspirational. Dr. Grant has been a valuable colleague for over 16 years, playing a vital role in the developing and expanding genetic testing and genetic counseling services within our office. Dr. Stram and I have worked on a range of cases for over 5 years, bringing a deep understanding of molecular genetics in forensic medicine and experience in communicating with family. Dr. Marion, who co-founded the Montefiore Einstein Cardiogenetic Clinic, has been a loving and supporting presence, offering precision medicine level of clinical care and social support to families who had lost their loved ones. Dr. Marion and Manisha Sebastian, their genetic counselor at the Montefiore and Einstein Cardiogenetic Program, played vital roles in supporting families during the period when our office faced a gap in genetic counseling service due to the interruption caused by COVID, until we welcomed Sarah Sexton, our sole genetic counselor, in 2022. Some of the panelists I have had the pleasure of meeting more recently. Dr. Celine Gonder, who helped all of us made it through the COVID pandemic with her strong reports and analysis on CNN and other media outlets, tragically lost her husband in December 2022 due to aortopathy, a condition diagnosed by Dr. Strand in our office. Her steadfast support for our laboratory testing and the genetic counseling service has been invaluable. I also recently reconnected with Dr. Susan Lieberman, who is writing a book about her family's journey of dealing with a genetic disease that increased the risk of sudden death. Most importantly, as a result of Dr. Lieberman's effort in pursuing the gene change affecting her family, we're able to expand one of our testing panel by including that gene. Consequently, we have detected several pathogenic variants and have helped several other families since our testing. You can find a link to the shorter version of Dr. Lieberman's book on the event page. And we will hear directly from uh, them today. Furthermore, I would like to mention 5 pre-recorded presentations made available in advance for your access. These presentations offer valuable background and insights into various aspects of postmortem molecular diagnostic testing. I will just briefly summarize the key points here. Dr. Graham provided an overview of the historical events that lead to the full implementation of molecular autopsy uh, 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 in our office. He also reviewed practice guidelines and molecular autopsy, highlighted the challenges hindering broader implication of molecular autopsy across the United States, and offer valuable insights into what must be considered when introduce molecular autopsy to an office with limited resources. Dr. Graham also shared his vision for the future, emphasizing the ongoing work needed to enable our office to support other medical examiners' offices and family who had tragically lost their loved ones. Dr. Straham's presentation shed light on the forensic pathologist's perspective when it comes to conducting a molecular autopsy, drawing from her own extensive case study experience. She covered a range of topics such as pre-autopsy considerations, investigative factors to take into account, how autopsy finding can inform the selection of a proper testing, and seamlessly integrate molecular results into the determination of cause of death, and essential consideration when communicating with the family. During my presentation, I explained the current testing panel in our office, the workflow from testing request, variant interpretation, reporting, and genetic counseling. I demonstrate the utility of each panel using selected publications and previously unpublished case examples, emphasize the invaluable support we have received through NIJ grants. Furthermore, I touch upon the future directions we envision for our laboratory testing and genetic counseling services, highlighting the exciting perspective that lies ahead. Dr. Marion's captivating presentation revolved around the impact of a molecular panel on the living, drawing from his experience at the Montefiore Einstein Cardiogenetic Clinic, which is the which he co-founded back in 2006. He skillfully navigated through the concept of precision medicine, highlighting why post-mortem molecular testing is an essential component for achieving precise diagnosis and tailored treatment for family members who have suffered the loss of loved ones. Using the compelling case of Mr. P as an example, he posted a thought-provoking question about the timing of discussing the risk of cardiac arrhythmia disease with a teenager. Should a 16-year-old be empowered to make decisions about the testing that can significantly impact their own life? Sarah Sexton, our soul genetic counselor, spoke about basic concept of genetic variants, emphasizing how the intricate interplay between genetics and environmental factors can give rise to the complexity of disease manifestation. What a positive, negative, and a variant of uncertain significant report mean for the uh, cause of death determination and to the family. She also elaborated essential consideration for counseling for the family member following detection of a pathogenic variant through postmortem testing. Uh, she ended her presentation with a powerful message that postmortem genetic testing can save lives. So in today's roundtable discussion with the experts from each panelist, we aim to explore deeper insights, discuss our experience and challenges, and identify opportunities for improving in the field of postmortem molecular diagnostic testing. So now I would like to introduce the two family representatives who are physicians and scientists themselves. You can find their full biograph at a website. So first, we welcome Dr. Celine Gonder. Dr. Gonder was a physician trained at Princeton University, Johns Hopkins University, and the University of Washington and Harvard University. Dr. Gonder is an international renowned internist, infectious disease specialist, and epidemiologist. She has numerous media uh, appearances that we are very familiar with her work. So I just want to say very grateful for her again now to speak publicly about her own experience. And the second family member is Dr. Susan Lieberman. Uh, Dr. Lieberman is a geneticist, Uh, she completed undergrad study at MIT, master study at Harvard, and a PhD study at the University of Rochester. She's a distinguished professor at the University of Illinois and a research professor now at the University of Nevada, Reno. So let's, I think that's the end of my opening uh, remark. Let's give the to Dr. Gonder and Dr. Lieberman to talk about share their family experience and insight with us.
Well, thank you so much for having us, inviting us for the panel today. It's really an honor to be able to speak with all of you and to share what me and my family have gone through over the past year. I'll just briefly describe what happened, how I learned the news, and sort of how things unfolded from there. It was a Friday towards the end of the workday. I was on a Zoom with a colleague and was just preparing to wrap up our conversation, and started to get all of these text messages and calls on my phone, and was sort of ignoring it initially, but then it was just so persistent. I looked to see who it was, and it was the same person. And this guy, Gabe Marcotti, who's a longtime friend of me and my husband's, a colleague of his in the soccer journalism world. And so I thought, well, something must be going on. They were both in Qatar at the time, covering the Men's World Cup last fall. And so called him back and learned that my husband had collapsed at the stadium while covering the Argentina-Netherlands game, that some of the other journalists and other bystanders in the press box had started CPR. He had not gotten any shocks, but was transported to the hospital, and that some of his other colleagues were en route to the hospital with him. In the day or so before this happened, Grant had complained of some, cold-like symptoms. It wasn't COVID. Being a good infectious disease doc, I'd sent him over with his COVID tests and some Paxlovid in case he needed it. And it wasn't that. And he was fully vaccinated prior to going. But he had been complaining of just feeling fatigued, some lightheadedness, a bit of a cough. And after I got that initial news of him being en route to the hospital, tracked down the ER emergency room attending at the hospital, finally was able to speak with him. And it was probably about almost 2 hours after that initial news that I found out that my husband had died. And we didn't really know very much at that time as to what might have happened. First thing that crossed my mind was a pulmonary embolism, because he had taken this long flight to Qatar, maybe something like that. And things got a little bit, things got very complicated very quickly, and in ways that frankly did not surprise me. Rumors started to spread that maybe this was related to COVID vaccines. You may be familiar with other people who've had sudden cardiac arrests, for example, Damar Hamlin or Bronny James, LeBron James's son. and how quickly rumors emerged that maybe those were related to COVID vaccination. And as somebody who had worked on the Biden-Harris Transition COVID Advisory Board, had seen a lot of this kind of thing happen during the pandemic. And so that started to circulate. My brother-in-law was also concerned that this might have been the Qatari government that did this. And that was related to my husband being prevented from attending or going into the stadium when he was wearing a t-shirt with a rainbow flag. My brother-in-law is gay, and my brother-in-law was worried that this was some kind of retaliation, which it was not, to be clear. So I really had to snap into action very quickly upon learning the news. After informing my family, called a very close friend of mine who worked in the White House at the time, who then lined up others to assist in getting my husband repatriated as quickly as possible. And so that involved waking up the U.S. ambassador in Qatar in the middle of the night to have him start coordinating things with his staff to smooth things over with the Qataris, given some of the rumors that had already started, and to have him brought back here. And I also had help from our health commissioner here in New York City, because normally when somebody does not die in New York City, the autopsy would not be done by the New York City Office of the Medical Examiner. And so that was also really necessary to make this happen. At the time, I did not know that the medical examiner in New York City was the only one in the country to do molecular testing as part of the autopsy. That was just not something I knew. But as somebody who's also on faculty at NYU, who attends on the wards at Bellevue, this also felt like a very safe place for me to have this done. It was people who were essentially my colleagues doing this, who are among the best in the world. And I really needed for this process to be unimpeachable to put these kinds of rumors to rest. An autopsy in Qatar would just simply not have done that. And so with everyone's help, we got my husband back, I think it was a Tuesday morning. We went to meet him, his body at JFK, followed it back to the medical examiner's office. And I think within a day or so, we had preliminary results that this was, his death was due to a ruptured aortic aneurysm. And my husband had been an extremely healthy person prior to this, had never had any medical issues, was somebody who worked out 2 to 3 times a week with a trainer doing weightlifting, who used to be, was still a runner, but had gotten more into rowing in more recent years. So extremely, extremely fit person, didn't smoke, didn't use drugs. And so I knew it was going to be something out of the ordinary that causes sudden death among young people. I mentioned pulmonary embolism, aortic dissection or rupture is, also top of that list. So on some level, it wasn't shocking, but on some level, it still was that this would be the thing. And what proceeded from there was Dr. Ying-Ying Tang, facilitating the genetic testing, which did show a mutation in the fibrillin-1 gene. He did not have Marfan's per se, but it's the same gene, as I'm sure you all know, that's implicated in Marfan's. And Grant did not meet criteria for Marfan's, where his primary care provider thought it was indicated to test him. And that said, because he didn't have the Marfan's mutation per se, it probably wouldn't have made a difference here anyway. What he had was a previously unknown variant that we are still not entirely sure how that might have contributed to his cause of death. Since then, we have also gotten other family members tested, some of whom are carriers for the same variant. Number of them have also gotten both echocardiograms as well as CT aortograms to assess for aortic aneurysm. And we are working with Diana Milowitz at the University UT Houston in Texas and Houston to further characterize this variant, this mutation.
when I heard that Dr. Gounder would be on with me, I noted that we shared an experience many years ago, both attending the 1996 Princeton graduation. People don't think that sudden death is going to hit them. This is something to hit somebody else. And hovering over Princeton graduation in 1996, there was sudden death. On the left, you see my sister who was with us, and she was 54. And on the right, her daughter, my niece Karen, who was at that time 23. 4 years later, my sister came down with a cough, a persistent cough that wouldn't go away. They told her it was the flu, or it was bronchitis, it was pneumonia. Finally, her daughter-in-law, who was a family doctor, came for a visit and said, "You know, Mom, I think it's your heart." She went to see a cardiologist. She was in heart failure. He said, "It's never getting better. You don't have any family history. You don't have any diseases, drugs, anything that could have caused it. It was caused by a virus." The first I heard of long COVID. And in any event, her daughter, Karen, went on to have adventures. And by the time she was 36, she met the love of her life, actually re-met. He was a high school friend, Andrew, that she knew when she was in high school. And since she was 36 and he 37, well, he was also 36, they were worried about children. And lo and behold, right away, she got pregnant. And on the right, you can see, actually on the day of her death, Karen with her husband showing off her bump. That day, they went out to eat at a Colombian restaurant in downtown Brooklyn. And as Andrew recalls, she lurched upward, eyes wide, and then slid down. The EMT was there within minutes, but they were unable to restart her heart. An emergency cesarean section. Her son lived for a minute or two, but he could not sustain life. This was 28 years to the day after my father died suddenly of a heart attack. When my father died, I was with him. It was not sudden like Karen's. It was within an hour he died. The emergency doctor told my mother and me that this was a coroner's case, but my mother said, "Oh, no, we're Jewish, don't defile the body." And he said, "Okay, fine." I'm afraid, it still haunts me that had we allowed that autopsy, we might have gotten information that could have made an earlier diagnosis for my sister, who almost died of heart failure, and could have possibly saved my niece, Karen. Karen was brought to the New York City coroner's office, and Barbara Sampson was the pathologist who examined her and was unable to find the cause of death, but removed her heart and sent it for further study. And oh, by the way, yeah, I did mention about the virus. We got the report about a week later, and it sent shockwaves through the family. She had died of dilated cardiomyopathy, what they called idiopathic. There was no reason, but of course there was a reason. My sister had dilated cardiomyopathy, and it wasn't caused by a virus. It was caused by a mutation. So I, as a geneticist, I set forth to try to find the mutation. My sister underwent various testing. She didn't have any of the known cardiomyopathy mutations. I heard of Dr. Elizabeth McNally because her husband was a yeast geneticist and was in the community of yeast geneticists that I belonged to. So I became Dr. McNally's patient, and she really took care of my sister. She kept sending her DNA out for additional testing. And finally, the cost of full exomic testing was reduced to about $50,000. And Dr. McNally said, "I've got 5 patients here. I can't figure out what they are. I'm going to use my grant money and sequence their exomes," which she did. I moved to Reno about that time, and we weren't talking all that often. And she published a paper in 2014 hypothesizing that a splice site mutation in the FLNC gene caused patient named, which was my sister. But she didn't tell me because she wasn't sure that that was the cause. When my sister died 2 years later, I contacted her and said, my sister's dead. What's happened? And she said, oh, we've got this FLNC mutation. A lot's happened since I published it. And so she told me what it was, and that I needed to get clinical testing, which I did. And then she wrote a Dear Family letter, and I started contacting family members. Of course, the first two people to contact were my children. And I should backtrack a little. Before we knew the mutation, we were told to get echocardiograms every year. And my husband was not happy about this. He didn't want me to tell the children. He's afraid, they're of childbearing years. They're going to be afraid to have kids. So we compromised, and I was allowed to tell them, but only once. I wasn't allowed to. The compromise was that I wasn't going to remind them every 6 months or every year and say, "Did you do this?" And they. My daughter continued to do this. Apparently, my son was told by his doctor that since I wasn't sick, he couldn't get sick, so he forgot about it and never did it again. Apparently, there are physicians who don't know about penetrance. So after we found the mutation, I told my kids, "You're done." My daughter was thrilled. My son didn't know he was supposed to be doing anything. Then I set out to find other family members. Those who knew me were happy to take advantage of Dr. McNally's offer to help them do genetic testing. Those who never heard of me were very suspicious. What did I want from them? I did find 2 family members that I am suspicious, but I'm not sure they ever got tested. One my uncle had told me about, but he told me this was a fluke. It couldn't possibly be related. It was a man of 32 years old when he died. He was my father's cousin, and he left behind two young children, aged 2 and 4, who were now in their 30s, but they really didn't want to hear from me. And he had died snorkeling on vacation in the Bahamas. Those many years ago. The other was a young man in his early 40s who had heart arrhythmia, whose doctor said, "Well, you're just nervous." And he said he was going to check up on it. And we had a nice correspondence, but I'm not convinced he ever did. So it's not easy to get people to act, even when we finally have something to act on. I did want to mention the last relative. Well, so my father's mother died in her sleep. Also said to be heart attack. So, there was family history. We just didn't know it. We had no idea. And then there was another family history. My father had an older brother who was 4 when he died. My father was 2. And my grandmother was a dressmaker, and she had a huge mirror. And the story was, for over 100 years, that the dressmaker's mirror fell on the 4-year-old and killed him instantly. And so this was the story we all knew. But as I was writing this book on the family with the goal of promoting genetic testing, I decided to get the death certificate and see, how did he die? How did this kill him? And there was no mention of any accident or injury of any sort. The boy died of heart failure after a 5-day stay in the hospital. So my grandparents had manufactured this story to hide what they already knew. Before James Watson was born, before he discovered DNA, my grandparents had figured out that our fate was in our genes. They didn't want prospective marriage partners to figure out that their boys might have a bad fate. And so they lied, they moved, and they changed the story. But now, with your help and the amazing things that I saw from the recorded talks, we can actually change our fate. And thank you so much for all of the work that all of you are doing to save people's lives, people who don't know, who aren't yet frightened. So a sudden death you asked what it does to the family, first it gives this terrible grief, and then it gives this terrible fear. And you can help prevent it happening and alleviate, in my case, the fear. It was wonderful. The fear went away. My nephew did not want to get tested. His wife, the physician, felt that an echocardiogram was all they could do, and that was enough. But then there was another paper that came out that said that you also needed, that you could have a perfect echocardiogram and still drop dead. You also needed an MRI, and you also needed Holter monitor. And by then they decided to go through and get the testing. And we were blessed in that regard that both my nephew and I do not have the mutation. And so our families were totally relieved of this terrible fear. I guess that's most of the story. Thank you for listening.
Excellent.
And thank you for your work.
Thank you both to Susan and Celine for sharing your story and really putting into context the kind of information and answers that this type of testing can provide to families, as well as highlighting some of the complications surrounding gathering family histories and how difficult it can be to kind of have those conversations. So thank you for that. We look forward to your perspectives kind of moving into our discussion portion of our event. So to get things started, I was wondering if Dr. Gill and Dr. Paneri, as former presidents of the National Association of Medical Examiners, can you just maybe give us a little level setting of the general state of postmortem molecular testing within the medical legal field? And then we'll kind of open it to the panel to see maybe where it's going to go in the future.
Sure. You want me to start? Or?
Yes, go right ahead.
So, the introduction of new techniques and technology into forensic medicine always lags behind its introduction into clinical medicine. So we all, I think, are well aware that DNA testing in forensics is not just for identifications anymore, although the FIG and the genetic genealogy is opening up many doors for identification. This symposium is on molecular autopsy, and I'd be derelict not to mention the important role that molecular testing plays in infectious disease as well, COVID-19, myocarditis, et cetera. I would say that most offices around the country have been collecting blood cards, for decades. In Connecticut, we've actually, for the past few years, also been collecting purple top tubes on every autopsy as well. And as far as name accreditation, they require name accredited offices to maintain DNA samples indefinitely. But really, that's the only requirement they have at the moment. And I think I was looking through some of the autopsy standards in Maine, and they require offices to have access to forensic anthropologists and so forth, but they don't require offices to have access to a molecular lab. And I think that's something that we probably need to add to our standards. We don't have a good handle on the number of offices that use molecular testing, and I think that's a survey would be very welcome in this area. I know Kelly Keys. I dropped a little seed to her. She's with RTI, and she participates in this survey, this national survey of medical examiner and coroner offices they do every few years. And I suggested to her to add that option, that question to it. Cost has always been a limiting factor, I think, for a lot of offices. In the past, they used to cost thousands of dollars to do molecular testing. Now some of the commercial labs, at one point they were doing it for free. One lab was doing it for free for us. Now it costs us about $300 to do a full kind of cardiac panel, which I think if you look at the cost for offices to do some toxicology testing or even microbiology testing, that is well in the range of budgets. The last thing I would say is the types of cases. And I think when we have a negative autopsy, it's much easier to get some buy-in for testing when it's a young person, it's unexpected death, as opposed to a case where there's a clear kind of class 1 finding. when you see an aortic dissection or a pulmonary thromboembolism, some medical examiners might say, oh, I've got my cause of death, but they really forget about the proximate cause. What caused the aortic dissection? And that's what we really need to look at. And I remember in 2019 in Kansas City, Kathy Paneri gave a talk on hypertrophic cardiomyopathy and the role of molecular testing. So I'll pass the baton to Kathy to talk about her view of this.
Awesome, thanks, Jim. So yeah, I'm a huge fan of postmortem genetic testing. I see it as furthering our role as medical examiners and coroners in the field of public health, because we have a responsibility to help prevent deaths if we can. And my experience with the postmortem genetic testing has been invaluable. I have found thrombophilias that run in families. One of them started with a 15-year-old girl that died from cerebral venous thrombus. And then it tracked down into other siblings and other aunts and uncles, and very valuable information, because one of them was about to get the Johnson & Johnson vaccine during the COVID time, and that would be contraindicated in someone with a pre-existing clotting problem. So I actually just finished a case of a 21-year-old who just died suddenly while driving. Unfortunately, has some trauma and lived for a little bit, but he has a genetic mutation for Becker muscular dystrophy. And there was another young male that had died in that family. And then we tracked it back to the mother's side of the family, and then her aunt was tested and had it. So it's such an incredible value. I would rather spend the $300 on this type of testing for the families than $400 for a toxicology panel for a lot of these cases, because it's just provides so much information. And while there's comfort in being negative, as Susan was, there also can be reassurance in those that are found to be positive, because there's interventions that they can undertake. And it used to be that when we found a hypertrophic cardiomyopathy, we would just tell the families, yeah, you might want to get checked out. And that was really all we could offer. But now we can offer this testing for the decedent and then for the families. And there are interventions. They can get defibrillators, they can get monitoring, they can measure aortic aneurysm size until graft placement is needed. So I am a huge fan. We probably order genetic testing. It's not in every single case, obviously, but very low threshold. Probably 20% of our natural deaths we do genetic testing on now.
Excellent. Thank you both for sharing that. And does anyone else have any kind of more comments to add? No? Okay, excellent. And as you had mentioned, with the kind of cost of those testing going down, this is becoming a much more kind of common practice, or perhaps a practice that more medical examiners' offices are kind of looking into. So Dr. Graham, I didn't know if you could maybe elaborate a little bit more. We had mentioned the blood cards, but maybe elaborate a little bit more onto how to implement, or perhaps how to improve their sampling and testing procedures within their offices.
Sure, thank you, and good afternoon to everybody now, or for some of us it's afternoon. I just, to sort of carry on with a bit of the conversation that we just had, I feel like that this is, as Dr. Paneri said, is very active, life-saving work. And it's, for medical examiners, often the life-saving nature of our work is sort of a game of delayed gratification. Either at the end of a lengthy, criminal justice process, or getting a dangerous product off the market, or, the day-to-day gratification of telling families what happened. But this is active, life-saving work, and it really highlights the public health role that the medical examiner and coroner has, and the importance of that role. And I also have to acknowledge that none of the work that we're doing now would have happened but for Dr. Barbara Sampson and Dr. Ying Tang, who brought this lab into being here in this office. And so with the support of our chief, longtime chief here, Dr. Hirsch. So I just wanted to, Charles Hirsch, so I just wanted to mention that and thank them for the foundation and for the past 20 years of really growth and development of this lab that's going to help us move into the next level. I think to more directly answer your question, I think this has to become part of the culture. It has to, in an office, it has to be normalized from leadership in terms of the expectations for medical examiners, for doctors who are performing autopsies, to put in their differential diagnoses, molecular genetic causes of death that would, beyond the blood spot cards that we're all accustomed to keeping and have been doing, like Dr. Gill said, for decades, and holding on to those forever. The sample storage, the additional samples that are better than the blood spot cards, either a blood sample or a tissue sample in RNA later. I think that, considering adding those when any genetic cause is on the differential diagnosis is really important. Thankfully, the costs are falling and it's becoming more accessible to more offices. And so I think making the genetic causes, ever present on the differential diagnosis, saving the appropriate samples and discussing these cases, making sure that, internally you have protocols that are going to ensure that you're not left without a diagnostic material at the end of a case. Identifying a lab, identifying a lab partner, a reference lab that you can partner with, and making sure that you are going to be able to meet their needs diagnostically based on your sampling procedures, which is very important. And I think we're looking forward to, we're going to start trying to extend this testing to family members internally in our lab, because we're finding that a lot of those folks, although we recommend testing and our genetic counselor deals with them, they're just not getting the testing they need. And there are so many barriers to that care that have to be addressed. But making the molecular genetics a part of the diagnostic conversation internally and normalizing it amongst your medical staff, getting appropriate sampling, and then identifying a lab, I think are really critical steps.
Absolutely. And you had mentioned the extra lavender top tube of blood, and specifically the mention of the RNA later. I thought that was important, as a lot of medical examiners are kind of standardized to formalin fix their tissue samples. And so just having that RNA later on hand can really promote greater genetic results and greater testing requirements. So thank you so much for sharing that. And another important kind of point you had mentioned is kind of the aspect of public health and medical examiners, coroners' offices' role in that, and that search for answers. So I didn't know if Dr. Sampson or Dr. Stram, if you'd kind of like to go into that a little bit more, as far as kind of finding the right answers, how that can affect the family, and kind of how you handle reporting those genetic results.
Certainly. Well, our job as medical examiners, if you have to sum it up in one sentence, is to determine the cause of death, and that result goes on the death certificate. The accuracy of the death certificate is paramount to every medical examiner for a number of reasons. Number one, of course, providing an answer to families, and in this case, impacting potentially surviving family members as well. But the accuracy of the death certificate is even more important than that. We mentioned just now public health, not only for the reasons we already discussed, but if no one is testing for these diseases, then there's not going to be nobody funding research into these diseases. So that's another really important reason for, the most accurate death certificates that exist are those that come after an autopsy from the medical examiner's office. So if they're not doing that testing, it doesn't mean nobody's dying of these diseases. It just means we're not reporting them. So that's another really important aspect of what we do. And I also want to mention that this work that we do really informs research at a basic science level. Dr. Tang has established many great collaborations with academic centers across New York City and beyond, looking at the mutations that we identified. And that is yet another important aspect for furthering our understanding of these horrible diseases that kill often seemingly healthy babies and young adults. I also wanted to just add to what Dr. Graham, Gill, and Pineri were saying about funding. Funding, of course, of this testing by medical examiners is difficult. We were very lucky in New York City to have a very well-funded DNA lab already up and running 20 years ago, and we could add this on basically under the radar for a little while until we got important results, like the results that were described today. But once you have a few of these case studies to present to the politicians, they are entirely on board. They can easily relate to how important having an answer when your loved one dies is, and especially if it impacts living family members as well. So I want to encourage medical examiners to keep seeking the funding for this, because it is there. You will find the will with your government agencies. Michelle, you want to go on?
Sure, yes, absolutely. So I think that every single document, from the death certificate to our autopsy report and the molecular genetics report, each one of those documents that we generate is an opportunity to communicate all of the information that we're possibly able to communicate. So anytime pathogenic or likely pathogenic variant is found, I think it's really critical to include that information on each document, so that even if that death certificate is the only document that family has, it is still enough, both from like a vital statistics perspective, but also if they hand that to their primary care doctor, like that is already a starting point for that family to be able to have testing for other family members, and for whatever medical provider that family comes in contact with to have a better understanding of why, for example, a young person passed away suddenly of a cardiac death. And so I really would underscore to everyone that's watching that each of those should be seen as an opportunity for us to make a difference for that family.
Absolutely. And you had mentioned that there hasn't been a lot of guidance regarding kind of where or how to report those, regarding if it should be a line 1 or a contributing factor or a line 2. Do you guys have any recommendations or kind of common practices that you found helpful in your offices?
Well, we're always looking for the underlying cause of death. So usually, for example, in an aortic dissection, we would say the ruptured aortic dissection due to the mutation, and have the mutation be the underlying or approximate cause of death. Very rarely, but sometimes we would find a mutation incidentally that really didn't contribute directly to or indirectly to the cause of death, and then that is not really appropriate to report on the death certificate itself, but we would definitely communicate it in writing through the autopsy report so that the family has it in writing. And in addition, by speaking with them, and I'll just preview the importance of the genetic counselor in having these discussions with families and connecting them to appropriate follow-up.
Yeah, some of the hereditary thrombophilias might be a part 2, because you can only really have kind of one cause of death per person, and you may have post-operative complication, and so it may be a part 2. But I agree. Usually, we're looking, for the proximate cause, and usually they are.
Excellent. Thank you so much. And as you mentioned, these kinds of cases often do come up very suddenly, unexpected, and kind of the family's impact after the fact is just as important, and that family care, the follow-up care that the family is able to provide. So Dr. Marion, I didn't know if you wanted to go into a little bit more about how you kind of can help the family members address those genetic results, genetic variants, and then we're going to go a little bit into the Genetic Information Non-Discrimination Act of 2008.
Yeah, sure. So thank you, Erica, and I'm honored to be part of this very distinguished panel. I want to really thank Dr. Gounder and Dr. Liebman for their eloquent description of their
personal stories, which really point out the fact that when you're dealing with a decedent, it's not an isolated individual, but part of an extended family. And the findings that you make at the time of postmortem exam have repercussions for first-degree relatives, children, parents, siblings, second-degree relatives, cousins, and on, like throwing a stone into a pond and watching the waves reach out to the rest of the family. And that's really what we do in our clinic. And I think Monisha will talk more about that in the genetic counseling part. We really are dealing with families who are coming to us in times of crisis. They're coming after having experienced the loss of a loved one. They're grieving very often. And at the same time, they're here to find out that whether they may be facing the same outcome that their family member, their loved one has experienced. And it's obviously a very stressful time for them. And so it's important to provide them with the needs that they have for grieving. So that's part of what we do in our clinic. I'd also like to say that the importance of the medical examiner doing the genetic testing can't be underestimated because of the fact that if a family comes to us after the death of a baby or a child or an adult, one thing that we found is that once you die, you lose your health insurance. And so even if there's DNA available, we have to find a lab that will do it, and the family will either have to pay for it out of pocket, or we'll have to throw ourselves on the mercy of the lab that's performing the testing. So that's something to keep in mind. There are all sorts of issues that come up with testing family members, extended family members. Some of those involve a discussion about insurance. So the Genetic Information Non-Discrimination Act of 2008, or GINA for short, prevents insurers, health insurers, and employers of companies that have greater than or equal to 15 employees from discriminating against individuals on the basis of their genetic test results. So in other words, if we find a decedent who has been found to have long QT syndrome type 1 because of a potassium channel mutation, and we want to test his or her children, we have to, tell them beforehand that if they test positive, even though they're asymptomatic, they will not be discriminated against. They will not lose their health insurance or not be insured. However, GINA doesn't apply, doesn't protect from discrimination in life insurance, disability insurance, or long-term care insurance. And so before we rush out and do testing, we have to have a discussion with the family about that information. And they have to decide what they want to do on the basis of that. So that's really the insurance issue. There are also some ethical issues that were brought up, and I think were especially brought up in the case of patient Mr. P that I described. So Mr. P was a 57-year-old man who didn't actually die. He was bicycling, or he was exercising. He fell to the ground, had a cardiac arrest, was resuscitated, but was found to have a sodium channel mutation that we believed was responsible for his episode of sudden death. And he had a son who was 16 years old at the time of his event. And although we found this variant in Mr. P, the parents didn't want to test him, didn't want to even tell him that he was at risk for possibly having inherited the same variant and therefore of suffering the same fate as his father. And we were kind of stuck. And so the question comes up, who owns the information? Who owns the genetic test results? And is there an obligation on the part of the person who is tested to tell other members of his or her family so that they can be tested? And there are some regulations about this or some recommendations about this. The American Academy of Pediatrics recommends that decisions about whether to offer testing should be driven by the best interest of the child, that genetic testing should always be offered in the context of appropriate genetic counseling, which again, I think Sarah and Monisha will talk about in a minute. Parents and guardians may authorize testing for asymptomatic children at risk for childhood onset conditions, and ideally the assent of the child should be obtained. So the child should be asked about this and give his or her permission. Predictive testing for adult onset conditions should be deferred unless an intervention initiated in childhood may reduce morbidity and mortality. This is really so that the child can make the decision for himself rather than a parent deciding in a 2-year-old, say, who may have a condition that will develop much later in life. The child should be the one to really make that decision. For ethical and legal reasons, providers should be cautious about providing predictive testing to minors without the involvement of their parents and guardians. So in other words, it really is important to get the parent and guardian on board for this. And so in the case of the P family, we worked on the parents for years to try to get them to agree, even after Mr. P's son reached the point of adulthood. They still would not disclose the information to him. Fortunately, he came to a point where he was getting married, and his fiancée said, basically, I won't marry you unless you have this testing done. And he did have the testing done, and he turned out not to be a carrier of the variant. I think the take-home lesson of this is that you can't just rush in and test people because you found a variant that is pathogenic in the decedent. You have to have long discussions with them, discuss the pros and the cons before actually, sticking the needle in the person's arm. So again, thank you for inviting me.
Excellent. Thank you so much. I think that's a great transition into our discussion with our genetic counselors. As you can tell, the family dynamics and the kind of repercussions of this testing can reach many individuals. And so having a genetic counselor, Sarah Saxton, is one of the first to be employed through a medical examiner's office. But we'd love to hear a little bit more from Monisha and Sarah as well. Just kind of any lessons learned or kind of the impact you can play in having these conversations with families.
Sure. I want to thank the panelists and Dr. Tang, Erica, and Sarah for inviting me to be on this panel, and everyone for sharing your expertise. And Dr. Marian, thank you for touching and leading into the genetic counseling conversation. As Dr. Marian pointed out, one of the biggest challenges is talking to these families who are still grieving. And in the case of individuals who are referred from the OCME in New York, it is pretty straightforward because we know what the cause or what the variant is. But in the case of families who are referred from outside of New York City, who've had only an autopsy it's more of a discussion of testing the individual who is asymptomatic, because other medical examiner's office, as pointed out by some of our panelists, the way the samples are preserved, some majority of the labs do not accept samples. So it's a challenge in also collecting the family history, where we're pretty much putting the individuals to go through or live through the memory of the loved ones who passed away, what the circumstances were. So the role of the genetic counselor, I think, is not just in discussing about the genetic testing, the pros and cons, but also providing counseling simultaneously. And sometimes we have to do 2 sessions. Families hear about the pros and cons of genetic testing, and it's too much for them to decide in a single visit. And at times, there are families who decide that they want to go back, think about the GINA part, the insurance part, and make decisions because the variant identified is associated with adult onset condition, and they want to think more about testing the minors. And there are also family dynamics where the relationships are not the best between different family members. For instance, if the dissident is, say, a male, and the wife of the dissident, the widow of the dissident, and the first degree relatives might not be in the best relationship. So whoever has ownership of the autopsy report pretty much controls what information is shared. So being this mediator between the families and bringing their focus to the common goal of saving someone else from going through a similar pattern is, I think, another aspect of genetic counseling. And to touch on what Dr. Sampson mentioned about the importance of what is reported in the autopsy, right now, a lot of movement in the genetics world is going towards genome and exome sequencing. So we are moving away from panels. And as many of you on this panel can appreciate, not genetic testing does not always come back with a finding. Majority of the time, we are left with an uninformative or an inconclusive or a negative result. And in many instances, it doesn't lead us to anything further. And in a clinical setting, we would typically approach proceeding with a more expanded testing like exome or genome. And these are tests that are more phenotype driven. And having a detailed autopsy report plays a significant role in deciding or in helping the labs, the testing labs, with the appropriate phenotype to perform the test. And with the other aspects that we see is also sometimes families find it too hard to go through this testing or go through this process. And we've had some families who, despite multiple contacts, would like more time. And in those instances, we have to respect their emotions and leave the ball in their court and ask them when they would like us to reach out to them for scheduling a visit. And this can take anywhere from a few months to sometimes even years that they need to go through this process. Sarah, do you have anything else that you'd like to add?
I guess I'll sort of add on to what you're saying is that in working at the medical examiner's office, I somewhat help transition families from learning about the cause of death, how genetics contributed to it, and transitioning them over to getting connected with the clinic. And sometimes that does, again, take multiple phone calls. Sometimes I'm talking with multiple family members if the initial contact isn't comfortable talking about the genetics with the rest of the family. And so I would just say keeping language simple so that the family can communicate those results with the rest of the family so that they have an understanding and so that they can go to a clinic and get genetic testing and further understanding of what those test results will mean for them.
Excellent. Thank you guys so much. And I think that it's such an important role of kind of the family impact, again, as we saw with Dr. Gounder and Dr. Liebman being here. I wondered if you guys had any more to add kind of from the family's perspective of the role of the counselor. Your guys' background is obviously more genetic and medically focused, so you're a little bit more informed, but I didn't know if you'd like to provide any perspective.
I actually would like to say that listening to you made me feel a lot better. I spent 2 years tracking down family members, contacting them, and when I finally found 2 families that I think were very suspicious, they didn't want to hear from me. I felt really bad that I had failed them somehow. First I spoke with the widow and she promised to tell her son and daughter. I felt she really didn't. I was able to find the son. I spoke to him and he didn't really want to hear from me either. And nobody would ever let me know about the daughter. I don't know if she's still living or whatever happened, but I was unable to reach her. I did want to mention a couple of things that I had forgotten, if this is an okay time. One is that when there were a few other people who had the exact same mutation as in my family to the nucleotide, I corresponded with that set of authors, and it turned out that these 2 families were also Ashkenazi Jews, and that led me to look at the IBD internal. Anyway, it's an exome site at the time that was the most famous, and 1 in 800 Ashkenazis had that mutation, whereas no other ethnic groups had it. And so one of my questions was this new to my sister? My daughter has a mutation that's new to her. Well, no, this mutation had been around for many, many years, many, many generations. And the other thing I wanted to mention was that I got to know Dr. Tang and Dr. Sampson because I took out the autopsy report and I spoke with Dr. McNally. I said, well, shouldn't we find out if the decedent, had this mutation? And she said, well, if you can get the DNA. And I called Dr. Sampson and she remembered the case immediately and put me in touch with Dr. Tang, who provided the material necessary. And we were able to get it sequenced. Both Dr. McNally sequenced it, and then they sent it to GeneDex, and they sequenced it, and they never billed me. I don't know why. But
you're pointing out the fact that and you alluded to this when you spoke earlier, the fact that there may be decreased penetrance. In other words, not everybody who carries the variant will wind up manifesting the phenotype. And the other thing is that there may be variability in expression, so that, for instance, in Karen's case, she was pregnant. It may have been the stress of pregnancy that led to her getting sicker and having this episode occur. So that may be running through the family, and a geneticist should be able to track, medical geneticists should be able to track that through the family. That was something that happened with our family, where the guy went down after exercising. We found in the lab that his sodium channel worked under normal conditions, but when he became acidotic, and there were a series of events that led to that, it wound up deforming the protein and leading to the channel no longer working. So it's those kinds of things that a geneticist can identify.
Yeah, even the 4-year-old who died, we were told later that it's unusual for a 4-year-old to die of an FLNC mutation. Maybe he had a virus in addition. So
Correct.
Something else. It was a combination of things that caused the death. But meanwhile, we have this underlying mutation. And that's why I did not understand my niece's resistance to testing. She was too frightened. But to me, you may or may not die of this mutation. You don't know if you're going to die or not if you have it. And if you don't know if you have it, you may or may not die. So it's not that different. There's uncertainty whether you find out you have the mutation or whether you don't. The only thing you can be certain of, although I figured out I'm going to die anyway, is that if you don't have the mutation, you're not going to die of the mutation.
Right. But everybody's different and have different beliefs and that was something that occurred in the P family as well. The mother not wanting to test her kid because she thought that testing him would mean that he had it. She understood the implications, but it was not logical.
I'll just share a little bit from my own family's experience here as well. I think many families have, I think it's very common for there to be dysfunction in families where some people aren't talking to one another. And like many families, that was the case with my husband's family. And so that made it challenging to track down certain relatives and to talk them through this. I think that's the norm, not the exception. And then I think, you know, sort of echoing what Susan and Bob were just saying, I think a lot of people, it's a combination of othering, where this happened to you, but you're not me, I'm not you, this couldn't happen to me. And it's a form of psychological protection, denial. I think that's also extremely common. And then this idea, you know, and me as somebody who also sees patients still, this idea that the test gives you the disease, I think is also very common. And to just expect that those are going to be some of the areas of resistance you're going to face, and, you know, just be prepared. You know, as somebody, again, who's a physician and work in a different space as an infectious disease doctor and epidemiologist, I also have areas where I have patients who are resistant to something like getting their COVID vaccine. And, you know, this is something where it's not a one-time conversation. It's really showing that you're trustworthy, that you're curious, that you're invested in them. And over time, you know, people come around if they feel that you really have their best interests at heart.
Excellent. Thank you for sharing that. We do have some questions filtering in, so we will go ahead and jump into those. So the first one is, what innovative approaches do you all envision for integrating advanced molecular autopsy techniques into more traditional forensic practices to enhance the accuracy and efficiency of cause of death determination?
I can take up this
Yes, go right
question.
ahead.
Actually, quite extensively discussed in the 5 pre-recorded presentations. Basically, if a medical examiner's office haven't had started doing molecular diagnostic work, I would, you know, first thing I would say, save a variable sample. Like Manisha mentioned, some of the medical examiners' offices, they don't even have a bloodstain card. And we, from our own work, we have tested. We're really trying to use a formalin fixed sample, and then we actually realized the formalin fixed sample in the medical examiner's office is quite different from those in the clinical setting. When they do quick fixing, maybe just, you know, less than an hour, fixing a formalin, and then they quick look at the slides. So you see research paper talking about, oh, FFPE samples are good for molecular diagnostics. However, our own experiences, the formalin fixed sample in medical examiner's office create not only gave poor sequencing results, but also gave artifacts that due to fixation of a formalin, create cross-link and then create nucleotide changes. And what happened is, if you only have this formalin fixed sample for a case, and you identified a change in the, we call it a variant in the gene, you don't even have other sample, like you don't even know it's true what is the artifact. So therefore, making the molecular diagnostic inaccurate. So I think first thing is should be for a medical examiner's office to have a policy, whole agency, whole office level policy to save a variable sample for every single case. So I think that's a good start. And then we can talk about based on the phenotype, Is it a cardiac death? Is it epilepsy related death? Is it autopsy? Is it thrombophilia? So we could do panel testing, or is it completely negative autopsy? There is perhaps we have to do more expensive, like exome sequencing or whole genome sequencing to identify. So I felt like I don't know if it answers your question. So I highly encourage you to watch the recorded 5 presentations. Hopefully you'll find some answer there. And the quick answer is what I can provide it here. Thank you.
Dr. Paneri, did you have something to add? Sorry.
I was just going to mention that in an ideal world, we would save samples and on everybody and for availability, but we are all restricted by constraints within our own buildings, our sample storage. These aren't the only samples we're saving, and so there is a little bit of a challenge there. But I think the way to get this more widespread is things like this, getting the word out, because I learned something new today. I just placed an order for the RNA later, so that we'll have that for our case now. So it's just getting the word out is really what it is, because the technology is there and it's only going to improve and get better over time. So the more we have available to test, the better it will be. But the sample storage is the number one.
And I would like to add, I would like to add, I think part of this educational event is trying to understand what are the challenges, what are the needs, gap of understanding. After I felt I personally learned so much from each one of you, and I felt after this event, if we could, probably there's a need for us to generate written documentation, including guideline for how to integrate molecular autopsy in standardized forensic investigation, and how to start with sample saving, how to identify laboratory could help them, and how to understand different type, complexity of the testing report, and a complexity of speaking to the family. Really needed, genetic professionals to be able to speak to guide family members. So I think probably that's the next step for us to generate such document. Will be beneficial to the medical legal investigator field in the field. Have a border, dissemination.
Absolutely. And we had one comment. It says, as a national patient advocacy organization for aortic dissection, unfortunately, many families come to us after the death of a loved one. Given the number of different jurisdictions, we see a huge variation in who is offered autopsy, what samples are saved, who pays, etc. So I think this goes into kind of creating those standards. And they kind of say what research could be done to demonstrate benefit and kind of create those standards around that. And so I was wondering if we could go into a little bit kind of, as she had mentioned, the variation of procedure, especially in some of these kind of heart-related conditions in older patients. Have any of you kind of found case clues that maybe indicate further genetic testing if there's no phenotypic results that you would recommend kind of pursuing this type of testing for?
I would, oh, sorry. So I would say that really begins with the history, having a really excellent history that's provided by your medical legal investigator. That at the get-go really gives you a very strong idea of where a case is likely to be headed. So before the doctor even begins the examination, they are receiving a lot of information that will direct what they're most concerned about in a case. And so having a very structured interview that you're setting up with your investigators for the types of questions that the doctor needs the answers to in order to approach the case correctly is very helpful. And that can really also begin to help guide what cases will ultimately go on to testing.
Excellent. Yes, go ahead, Dr. Perry.
Yeah, so I think the key to that is getting the autopsy done, and the access to autopsy is not uniform across the US, unfortunately. You know, if you're in a rural area and you're 45 years old and you die suddenly and the paramedics say it's a heart attack, you may most likely won't be getting an autopsy. They don't have the funds to pay for that. And so it really just depends on where you live and what access you have to those services. And even if you do live in a busy office, most likely they're overrun with homicides and drug-related deaths too, so they may not do a full autopsy on individuals as well. So we're in a really critical workforce shortage right now for forensic pathologists, and there just aren't enough of us to do the work, despite how valuable it is. And so it's really kind of a battle that we're all struggling with. Some offices have reduced their level for autopsy to 50 years old for natural deaths. And as that number's come and gone for me, it kind of hits close to home that I don't have any medical problems. So if I dropped dead, I wouldn't necessarily get an autopsy in where I live. So in my jurisdiction, I would. So it really just kind of depends on where you live and what the resources are. And the answer to that is money, and we're not getting enough, and resources to do the work.
Dr. Graham.
Yeah, I certainly agree with all that she just said, Dr. Perry, but you know, a lot of these cases, if they make it to the hospital, we would get the cases that die in the field, that die at home or on the street. But the cases that get to the hospital, that get a diagnosis of aortic dissection, for example, in the hospital and go on to die there, those may not even be reported to us altogether. And if they are, many of them likely jurisdiction would be declined just because there's a natural explanation for the death. But it goes back to something Dr. Gill mentioned earlier on, which is thinking toward proximate cause. The etiologically specific reason or the proximate cause certainly in a younger person, but really, you know, across the spectrum of, you know, from everything, you know, the cardiac disease to epilepsy to pulmonary thromboemboli, the proximate genetic causes that may be at play that, you know, that testing can be done in the setting of a hospital autopsy. But, you know, the cases that come to us are, you know, having a low threshold of suspicion and thinking proximate cause-wise. Thanks.
And Dr. Gill.
Yeah, as far as the research that can be done to demonstrate the benefits and so forth, you know, I mean, I think continuing to publish reports about these cases, and actually, you know, it'd be wonderful to do a retrospective look, to go back 20 years and pull out those deaths that we certified as cardiac arrest of undetermined etiology or mitral valve prolapse, and do the testing on those. I mean, we have those blood cards, and to be able to present that and say, look, we went back and looked at all these sudden deaths that didn't have and we found that 30% of them had a molecular explanation. And I think that would educate a lot of people and be a powerful research project.
Well, thank you, Dr. Gill. And Dr. Lehman. Oh, your mic's on.
Even when families are offered an autopsy, the general public thinks of an autopsy as something in case there was a poisoning, or, you know, they don't want to be associated with that. They don't realize that the autopsy could save their children's lives. And we need to educate people so that, I mean, it's sort of an unpleasant thing to think about your relative's body being touched. And especially because, after all, they're touching it to accuse you of killing them. But we need to understand that it can save lives.
And now that I work at a hospital with the autopsy service, the clinicians also need to be educated on the value of the autopsy so that they explain to the families, and the families give permission for autopsies in these kinds of cases. And that is not happening even in a big academic center with, you know, who does a lot of autopsies.
Yeah, the physician who told us no, he was doing us a big favor by not pushing on the autopsy. And I didn't realize till years later.
Excellent. Well, we are at the top of the hour. If people can stick around, I didn't know if anyone liked to share their final thoughts or any kind of topics we haven't touched on before we close out for the day. No, good. Okay. Well, with that, we are out of time for any other questions, but please feel free to reach out to any of our panelists for additional information, or if we didn't have time to answer your specific questions. Their full biographies, as well as all their contact information, are on the course page, as well as on the slide you'll see today. Thank you so much for attending, and thank you to all of our amazing panelists for being here with us today. Yeah, have a great one.
Thank you.
Before you leave today's webinar, I'd like to draw your attention to our feedback form. It takes less than 5 minutes to complete and can be accessed via the checkbox icon directly above the chat. Your honest feedback is invaluable as we continually search for ways to improve and provide the best experience possible. Lastly, across the top of the live stream window are links to our social media profiles, including Twitter, LinkedIn, and Facebook. There is also a link to the FTCOE website, the Just Science podcast, and the FTCOE newsletter registration. Like, follow, or subscribe to stay up to date with everything the FTCOE is doing in support of the forensic community. Thank you again for attending, and we hope everyone has a great day.